So the next speaker is actually Dr. Ramakrishnan. So he's back onto the podium as a speaker. Laparoscopic pelvic lymph node dissection for rectal cancer. Dr. Ramakrishnan A S from ADEA, Chennai.
Thank you, Chairpersons. Thanks to the organizers and to my colleague Dr. Pradeep who helped me edit this video. So lap pelvic dissection for rectal cancers is not a very commonly performed surgery, as common as in other gynec malignancies. So this is a patient with a low rectal cancer, stage T3C-N2. He received neoadjuvant chemoradiation. Up front he had bilateral pelvic nodes, left side obturator and the right side internal iliac nodes. Following chemoradiation, there was a persistently enlarged obturator node on the left side, whereas the right side regressed, and therefore we decided to perform a laparoscopic APR with pelvic lymph node dissection on the left side. So the first step which I usually do is to identify and mobilize the ureter along with the uretero-hypogastric fascia. Now this is important because not only this forms the medial boundary of pelvic dissection, but it also helps to safeguard the hypogastric and the pelvic splanchnic nerves. So then you separate the vesico and the uretero-hypogastric fascia from the fatty tissue in the loose areolar plane. So once the uretero-hypogastric fascia is defined, that forms the medial boundary. Then you come on to the lateral boundary, which is the external iliac vessels. Now, unlike in other pelvic malignancies or penile malignancies, you do not need to completely clear the external iliac nodes because these nodes are non-regional nodes. However, by practice, because we do it very routinely for other pelvic malignancies, we routinely clear the external iliac nodes. This helps in identifying the external iliac vein and lateralizing the external iliac vein to enter into the obturator space. So it's important to safeguard the genitofemoral nerve on the lateral aspect of the external iliac vessels. So you completely mobilize all the fibrofatty tissue from the psoas muscles, which is under the external iliac veins, and go on to the obturator muscles. Laying bare the external iliac artery also helps to dissect the external iliac vein, which is right beneath it, and helps to clear all the nodal tissue from the external iliac vessels. So basically dissection is done in two compartments. One is the lateral compartment, which is the obturator compartment, and the medial compartment, which is the internal iliac compartment. And these compartments are separated by the obliterated umbilical artery. So as we proceed, I'll show you, we will identify the obliterated umbilical artery, which helps in identifying the various landmarks. So you complete the dissection around the external iliac vein. For this part, I feel it is better to use a monopolar source of energy because the work gets done much faster. So once you have cleared the external iliac vessels, you retract them laterally and you go into the obturator space. As you go into the obturator space between the external and the internal iliac veins, you identify the obturator nerve cranially, and from there you trace it caudally. You could also identify it caudally first and then come cranially, but this is how I do it. Again, the difference in a pelvic nodal dissection for a rectal cancer is you need to completely clear all the obturator nodes, including the deep obturator nodes, which is not commonly done for other pelvic malignancies like bladder cancers or cervical cancers. So as you go deeper into the obturator space, you come across the obturator vessels, the obturator artery and the obturator vein. So you continue clearing all the nodal tissue around the obturator nerve. You could do this by a split and roll technique because you cannot get around as a single block. So you cut anteriorly and then you take the specimen posteriorly to the medial side. You trace the obturator nerve all the way till it exits the obturator foramen, and here you can identify the obturator artery and vein. We will leave that for the end. You come back again, identify the bifurcation of the common iliac. From there, you identify the internal iliac artery, and you start dissecting along the anterior surface of the internal iliac artery. You have to clear all the nodal tissue along the anterior branches of the internal iliac artery. So as you clear the internal iliac artery, you will come across the obturated umbilical vessel. So here you are dissecting in the median paravesical space. So that's the bladder on the right side. So here the obliterated umbilical artery is coming into view. So you have connected the medial and the lateral compartments distally. So remember, it is very important to go deep down into the pelvis till you see the levators, because the rectal cancer metastasis is most common to the deep branches of the internal iliac, especially along the inferior vesical branches. So that is the obliterated umbilical artery from which the superior vesical artery takes off. It is important to try and preserve the superior vesical artery, whereas you could choose to divide the umbilical artery and as well as the inferior vesicle. So here we have decided to go ahead and divide the obliterated umbilical artery. It helps the clearance even better. But you could preserve it if you are meticulous enough. And then you identify the obturator artery. This arises from the lateral aspect, and this is usually the first anterior branch of the internal iliac. For this part of the dissection, I prefer to use ligature. And once the obturator artery is divided, the obturator vein comes into view. That is also divided and taken in a similar fashion. So all the fatty tissue and nodal tissue is removed from the obturator internus. That completes the obturator dissection. So that's the obturator vein. Which is divided as it joins the internal iliac. So once that is done, you go further deep down until you reach the level of the levators and clear all the distal branches of the internal iliac. And then finally, you come to the obturator vessels as it enters into the obturator foramen. This is usually the last step, and once that is divided, you could retrieve the specimen. So this is the completed dissection. You could see the medial boundary and the lateral boundary, that's the ureter and the external iliac vessels, and the internal iliac artery, the obturator nerve, and the divided obliterated umbilical artery. The final histopathology report, 6 lateral pelvic nodes were removed. Fortunately for the patient, none of them turned out to be positive. Thank you. I would be happy to answer questions.
Wonderful presentation, Ramakrishna. It's a difficult surgery, and to do it laparoscopically is commendable. If you could just tell, especially for the benefit of the PGs, that what are the situations where you will be doing such extensive surgery in the era of chemoradiation, because normally that would cover most of the indications.
So basically, for the benefit of the students, you could look at lateral pelvic node dissection in 2 situations. One is prophylactic and one is therapeutic. Prophylactic is when the MRI does not show any suspicious lateral pelvic nodes. Now, lateral pelvic nodes, I mean the obturator nodes and the internal iliac nodes. A suspicious lateral pelvic node now is defined as anything that is 7 millimeters or more in size. So, if there are no suspicious lateral pelvic nodes in a stage 1 and stage 2 rectal cancer, there is no need for a prophylactic lateral pelvic nodal dissection. In a stage 3 rectal cancer, in the absence of suspicious pelvic nodes, if you are giving chemoradiation, again there is no need for a prophylactic lateral pelvic node dissection. But as is commonly performed in Japan, where they avoid radiation for stage 3 rectal cancers, at least they used to do it earlier, that is the situation where you need to do a prophylactic lateral pelvic nodal dissection. Now, coming to therapeutic lateral pelvic node dissection, this is when the upfront MRI shows a lateral pelvic node that is at least 7 millimeters or more in size. Now, nowadays most of these patients receive chemoradiation. So, the question is, what do you do after chemoradiation? Do you routinely do a lateral pelvic node dissection, or you do it selectively? Earlier, this is a evolving guideline. The initial guideline was that any enlarged lateral pelvic node more than 7 millimeters in the upfront MRI, regardless of their response, you need to complete a lateral pelvic node dissection after chemoradiation. But then recently, there are papers which say that any persistent internal iliac node which is more than 4 millimeters in size, or any persistent obturator node which is more than 6 millimeters in size after chemoradiation, then you need to go ahead and complete a therapeutic pelvic nodal dissection on the ipsilateral side. So, this is in just the indications for doing a lateral pelvic node dissection.
Thank you very much for the clarification. That clears the, that's how we decide, and it's like I said, it's not an easy operation. You should not be doing it routinely. So you have to have those sort of indications to do this operation. Yeah, question.
Wonderful demonstration.
Thank you.
2 quick queries. Which are the 2 ports which you use for the left-sided dissection when you are doing this? So one is the right hand, looks like one is the right hand 12 mm port, and the other is the left hand usual working port as for LAR.
Yeah.
Okay. And if you are working on the right side, and so you probably that part was not there in this particular patient, so you would go to the left side of the patient and do that.
Yeah,
there is a bit of a visual disorientation at that point in time, because you are kind of doing the entire surgery standing on the left side of the patient, and when you suddenly move to the from the right side, and we suddenly move to the left side, there is a bit of a disorientation on the right left side kind of.
Not really, because these are the standard working ports that you would do for a abdominal penile resection or a low anterior resection. So I put 5 ports, 2 on the right side, 2 on the left, and 1 near the umbilicus. So use the same the contralateral side ports you use for performing the pelvic nodal dissection. I mean, I'm not sure. I mean, probably, yeah, when you start off, you might feel a little disoriented, but once you identify the anatomical landmarks, it is pretty straightforward. It is only a question of removing the nodal tissue.
On the medial compartment side, do you divide the superior vesical artery?
No. Superior vesicle, I always try to preserve.
Okay.
The obliterated umbilical artery, it is good to preserve it because it can be used as traction, and it helps in dissection. But sometimes, if you find it difficult to proceed beyond that, you could choose to divide the obliterated
and that would also be the caudal-most limit of the...
No. So,
so
it is important to go as low as possible, because the metastatic nodes are usually not found proximally. They are found
distally,
more caudally, especially along the inferior vesicle. So, it is very important because many times, especially if you, when you transition from doing it for a gynecological malignancy to a rectal cancer, in gynecological malignancies you don't go so deep. So you tend to underperform the pelvic nodal dissection. So it is very important to go and clear all the nodes right up till where the internal pudendal exits the Alcock's canal.
And a last question. So doing the rectal dissection first or the pelvic nodal dissection? Because in this patient it seemed that you've done some bit of the rectal dissection and the nodal dissection. Any particular reason for not completing the rectal dissection while doing the nodes?
As I showed you, the vesico and the ureterohypogastric fascia is a very important landmark to prevent damage to the pelvic splanchnic nerves. Initially I used to complete the rectal dissection fully before going on to the pelvic nodal dissection. But then I found that this fascia invariably gets disrupted when you complete the rectal dissection. So I just enter into the pelvis to separate a little bit of the rectum from the lateral pelvic wall, and then I start the pelvic nodal dissection. This helps to maintain the integrity of the uretrovesical fascia.
And you then bring out those lower left pelvic nodes as one specimen with the rectum?
Yes.
Thank you.
One last question from the back. While he's getting his microphone ready, can I ask you, when do you normally operate after chemoradiation? I'm sure you give long course chemoradiation for most of your patients.
Yeah. So the reason why this node turned out to be negative, even though on the MRI it was a significantly persistent node, was because we delayed the surgery for at least 12 weeks in this patient. This MRI was performed at 6 weeks, but for some reason this surgery got postponed. So normally we perform surgery between 8 to 12 weeks. We try to delay it as much as possible.
So that's another reason I was about to ask you whether we could have left these nodes behind, because at 12 weeks normally you get the maximum response.
So as I said, these are evolving changes as far as rectal cancer goes, the timing of surgery, response assessment, and whether or not to perform a nodal dissection. So what I personally feel is that we are coming to a time where we are going more into organ preservation and delayed surgery for rectal cancers. So many of these enlarged nodes, which appear enlarged at 6 weeks of reassessment, if you wait for a little while longer, they might regress even further, because radiation response is after all a time dependent phenomenon.
Yes. Can I add something there? I think important thing is, Doctor, he already said, was that this is an evolving area of knowledge. At a point in time, we would like, if there were enlarged nodes, you would kind of, even after chemorad, you would resect all. The biggest problem is if you have a lateral recurrence, the risk of which is significantly elevated if the patient doesn't meet the criteria of avoiding a lymph nodal dissection, is that you will have a deep pelvic recurrence, which is going to be very, very difficult to treat later on. This patient has already received radiation, you'll end up irradiating the pelvis again. So if there is a node which is seen on the pre-chemorad MRI, which is more than 7 millimeters, or as he said, obturator more than 6 millimeters and internal iliac more than 4 millimeters, even after chemorad, irrespective of when the MRI has been done, better to take it out. We have seen in 4 or 5 patients when even when the lymph nodes were small, even then that node had a residual microscopic focus. We don't know what would have happened to this patient later on, but we've had one recurrence and very, very difficult to treat.
Absolutely correct. So the point I'm trying to make is, if you wait a little longer and say maybe you do the MRI, repeat the MRI at 10 weeks, the node that was enlarged at 6 weeks might probably have regressed, and it might not meet the criteria for a nodal dissection.
The problem in interpreting it that way is that you could extrapolate it kind of from the complete clinical responses and recurrence there,
I think I'll have to cut
and the
short,
node coming
because
up again.
you have to, if you look at the recent evidences, the Rapido trial and all the total neoadjuvant therapy, the Optral trial, they're all suggesting to complete the neoadjuvant treatment completely. No. So if you have completed the treatment, the chance of having any residual disease is very small. And like he said, you repeat the MRI before you go in for surgery. Even at that point, if you suspect something, you'll have to do a lymph node dissection. There's no question about that.
I think that is where the importance is, that if there is something still suspicious, and in the rest of the patients we are still evolving.
So we all agree to that. Points well taken. Last question from the back.
So excellent demonstration, sir. I want to know, sir, if it's a one-sided nodes which are suspicious after chemorad, would you do only one-sided pelvic dissection, or you will go for bilateral?
No.
And second thing, in your experience, sir, how many of these nodes have come positive? Because in a limited series from Tata in Kolkata, what we have done, we have not found any nodes to be positive till now, although we have been doing dissection for last almost 2 years.
Yeah,
so I'm not sure.
That is what I was trying to say. See, most of the papers on lateral nodal dissection have come from a time when Surgery was performed 6 weeks after radiation. So the chance of persistent metastatic disease in these nodes is bound to be high. But nowadays, in major centers, because of the long waiting list and other reasons, surgery tends to get delayed. So by the time the patient actually gets operated, radiation would have had time to do its job. So the true incidence of positive nodes in these, positive metastasis in these nodes is quite low.
Thank you.
Thank you very much. I think with that, we conclude the session.